So as Tanya said, I'm Hallie, and today I'll be presenting bispecific antibody inhalation therapy as a means for redirecting stem cells from the lungs to repair heart injury, and specifically myocardial infarction. So myocardial infarction is the leading cause of death globally and is usually caused by a blockage in the artery, which prevents the flow of blood and the nutrients blood carries to the heart tissue. Eventually, the tissue dies from the lack of nutrients, and current interventions include medications such as blood thinners or, more commonly, surgery. Because the cardiomyocyte turnover rate is so low, the recovery process also involves remodeling the extracellular matrix, which means accelerating cardiac fibrosis and thus heart failure. Still, the vascular damage induced by myocardial infarction recruits platelets to the injured area. One type of therapy that has been investigated for myocardial infarction is stem cell therapy. It's promising because they've been shown to have a reparative effect on the myocardial infarcted heart, but applying stem cells in practice is difficult. First, the number of circulating bone marrow-derived stem cells is low. The stem cells have no targeting ability and therefore do not accumulate in the myocardial infarction area. And even when engrafted onto the infarct site, there is low retention. However, bone marrow is not the only site of biogenesis for hematopoietic stem cells. The lungs are also a reservoir for hematopoietic stem cells. And so, as I mentioned earlier, the vascular damage that is caused by myocardial infarction signals for platelets to migrate to the site of damage. And because the lung contains high concentrations of both platelets and hematopoietic stem cells, we designed antibodies that could bind to both the CD34 domain of the stem cells and the CD42B domain of platelets. That way, when the platelets are recruited to the infarct site of the heart, the stem cells will be attached to the platelets and brought to the site of injury as well. And the idea is that this solves the targeting and retention problems that currently face stem cell therapy for myocardial infarction. So the first step was to make the bispecific antibodies. CD42B, the platelet binding motif, was modified with TZ-PEG NHS, and this formed CD42B TZ. And then for the stem cells, we used CD34, which is the stem cell binding motif, and conjugated that to TCO-PEG NHS, and this formed CD34 TCO. And to make the bispecific antibodies, TZ and TCO were conjugated to each other. And this conjugation was confirmed by SDS page, which shows the sizes of the binding domains, semiproducts, and bispecific antibodies. We also used gold nanoparticle labeled secondary antibodies to confirm the successful combination between CD34, which had been from a rat host, and it's depicted with the 25, so the larger 25 nanometer gold nanoparticles, and CD42, which is for the platelets, and that was from a mouse host, and that's shown by the smaller 5 nanometer gold nanoparticles. And you can see that they do bind to each other. So now that we knew the bispecific antibodies were successfully created, we wanted to confirm that the antibodies could bind the platelets and the stem cells. We used confocal microscopy to demonstrate the ability of platelet targeting bispecific antibodies, shown here in green, to bind to the platelets, which are shown in red. And when quantified, you can see that the percent of total platelets that also had green surrounding them, meaning the platelets that had platelet targeting bispecific antibodies bound to them, was about 70%, which is considered a high binding efficiency. Separately, we also showed that the platelet targeting bispecific antibodies, which again we represented with green here, were able to bind to the stem cells, which is what the red now represents. We also used DAPI in these images to stain the nuclei blue. And in the left panels, you can see that the stem cells did not have the bispecific antibodies and did not have any green fluorescence. But in the middle panel, which has the bispecific antibodies, there is green fluorescence around most of the cells. And when quantified, the binding efficiency was again high at around 70%. And in the bottom right, we have a close-up view of one of the stem cells that had the bispecific antibodies bound to it. and the green puncta, again, those are the bispecific antibodies. So the next question was if the platelet targeting bispecific antibodies could bind the stem cells to the platelets. We used IgG bispecific antibodies as a control, so they didn't bind to the stem cells or to the platelets. And with confocal microscopy, you can see hardly any stem cells were bound to the platelets on the left side. But with the platelet binding bispecific antibodies, in the middle panel, you can see the way the purple labeled platelets and the green labeled stem cells overlap. And this indicates that the platelets and the stem cells were bound together, and the efficiency for that was between 30 and 35%. So having shown that the bispecific antibodies were successfully created and would bind stem cells to platelets, we moved on to an in vivo mouse model of myocardial infarction, in which the left anterior descending artery here was ligated. And to treat the mice, we used two different methods. We studied both tail vein injection and inhalation. And so for inhalation therapy, the mice that received the myocardial infarction surgery were placed inside a chamber, and the platelet targeting bispecific antibodies were added to a nebulizer cup, which then with the air compressor delivered the bispecific antibodies as an aerosol to the mice so that the mice could breathe in the antibodies at their natural breathing rate and did not need to be anesthetized. The bispecific antibodies were pre-labeled with dye for this, so the accumulation and retention of the bispecific antibodies could be observed with an in vivo imaging system. The in vivo imaging system was used to measure the mean fluorescent intensity of the organs at different time points, and since the bispecific antibodies were labeled with dye, we were able to track this. So we had 4 groups of mice, which included 3 groups that had MI surgery, and each of those groups, there was one with the platelet targeting bispecific antibodies inhaled. There were non-targeting, so IgG bispecific antibodies that were inhaled, and then there were platelet targeting bispecific antibodies that were injected via tail vein. And then the last group were mice that had a sham MI surgery and did receive the platelet targeting bispecific antibodies by inhalation. And visually, you can see that the fluorescent intensity increases in the heart the fastest and the strongest in the first or leftmost group. And that's the group that had the MI surgery and the platelet targeting bispecific antibody inhalation. And moreover, the fluorescence or platelet targeting bispecific antibodies was retained for the longest of the other groups, and this was up to 60 hours that we saw this. And we also observed that as fluorescent intensity decreased in the lungs, the fluorescent intensity increased in the heart, which lent credence to the platelet targeting bispecific antibodies being transported from the lung to the heart. And as expected, the non-targeting bispecific antibodies in MI mice and the platelet targeting bispecific antibodies in the sham mice only resulted in a negligible amount of antibodies that actually went to the heart. So something else to note is that fewer platelet targeting bispecific antibodies were transferred to the heart by IV injection, and that inhalation in the MI mice reduced the transfer of platelet targeting bispecific antibodies to off-target organs when compared to IV injection. And again, you can see the greatest mean fluorescent intensity in the lungs was at the beginning when they were inhaled, and that steadily decreased over those 60 hours. And in the heart, the fluorescent intensity gradually increased, peaked at 6 hours, and then decreased. So we also used immunofluorescence to confirm that the platelet targeting bispecific antibodies were able to travel from the lungs to the heart. After 1 hour of inhalation on the left side, the bispecific antibodies were found in the lung parenchyma, which meant that they were able to penetrate the respiratory tract barrier. And in these confocal images, the nuclei of the alveolar epithelial cells are stained blue with DAPI, the lung vasculature is stained red with von Willebrand factor, and the lung cells themselves are stained green with phalloidin. And the platelet targeting bispecific antibodies are stained gray. So the middle panel has the same staining, but instead of being 1 hour after inhalation, this occurs at 6 hours after inhalation. And we can see a decrease in the amount of platelet targeting bispecific antibodies in the lungs. However, there is an increase in the overlap of the bispecific antibodies in the lung vasculature at this time point. And this was also quantified on the right. So we can see the percent of pixels above a certain intensity decreases from 1 hour to 6 hours, but the percent of pixels that overlap with the VWF staining in the lung vasculature increases from 1 hour to 6 hours. And looking at the border zone of the MI heart, which is where the ligation of the left anterior coronary artery occurred, again, the cell nuclei were stained blue with DAPI, the cardiomyocytes are stained red for alpha sarcomeric actinin, and the platelet targeting bispecific antibodies are white. So comparing the method of delivery with inhalation on the top panel and then tail vein injection in the bottom panel, it's pretty clear that there are more platelet targeting bispecific antibodies delivered to the heart via inhalation. And we saw this when we quantified it. There is over 3 times the amount of bispecific antibodies delivered to the heart by inhalation as by IV injection. We also used flow cytometry to ensure that the platelet targeting bispecific antibodies bound to the hematopoietic stem cells and platelets in the lungs, and to study different time points. Again, we used 4 experimental groups, and these were where we had MI mice that inhaled platelet targeting bispecific antibodies, MI mice that inhaled non-targeting bispecific antibodies, MI mice that were IV injected via tail vein with platelet targeting bispecific antibodies, and then mice with a sham surgery that inhaled platelet targeting bispecific antibodies. And within 2 hours, you can see that the groups that received inhalation of platelet targeting bispecific antibodies had high conjugation of stem cells and platelets in the lung. However, at 6 hours and after, you can see that the signal reduces in the MI mice, whereas in the sham mice, or the mice that received the sham surgery, the signal stayed high. And so, as expected, the non-targeting bispecific antibodies had very little conjugation of platelets and stem cells. We also used flow cytometry to study the percentage of platelets conjugated to stem cells in the heart. And similarly to the IVUS images that we had previously seen, there was a gradual increase in platelet targeting bispecific antibodies in the hearts of MI mice via inhalation that peaked at 6 hours and then decreased. And in contrast to the tail vein delivery method, that peaked at 2 hours instead of 6 hours. So it seems to be a little faster, but when you look at the actual percentages, it resulted in a significantly lower percentage of platelet conjugated stem cells at that time point by almost 4 times that much. So even though it was faster, it still didn't have the same amount of delivery. In the mice with the sham MI operation, fewer stem cells were detected in the heart, which we expect and makes sense because in that case, platelets would not have been recruited because there was no actual injury. And so next on the right panel, the platelet conjugated stem cells were examined to determine the percent of which that were bound by the platelet targeting bispecific antibodies. And we were able to confirm, fortunately, that the stem cells were conjugated to the platelets because of the platelet targeting bispecific antibodies. We did some more confocal imaging and showed that the accumulation of the stem cells in the heart with the cardiomyocytes labeled red for alpha sarcomeric actinin, and then the stem cells labeled green with CD34. So you can see there are more stem cells delivered by platelet targeting bispecific antibody inhalation to the myocardial infarct heart than by IV injection. And in the other groups, there is very little green in the non-targeting bispecific antibody inhalation heart and platelet targeting bispecific antibody inhalation in the sham heart. We quantified the presence of stem cells by determining the percent by which the stem cell marker CD34 also overlapped with the DAPI. And the graph makes it even more clear that inhalation of the platelet targeting bispecific antibodies was more successful at delivering stem cells than any other group, including that with the IV injection. And then just another safety measure to confirm this, we used Western blotting, and these results did mirror the fluorescent images. So the expression of CD34 in the hearts were compared between the groups, and normalized to GAPDH housekeeping control. And again, we saw platelet targeting bispecific antibody inhalation in the MI hearts was much higher than any other group, including the IV injection MI heart. So after having shown that platelet targeting bispecific antibodies could redirect and were responsible for redirecting stem cells to the injured heart, we then studied the effect of the stem cell redirection on cardiac repair in terms of reducing apoptosis and inflammation. So 4 hours after MI surgery, the mice were divided into 4 treatment groups, treated, and then 3 days later, sacrificed for histological analysis. And we looked at 2 different indicators of apoptosis, caspase-3, which is the top panel in green, and then cleaved PARP, which is the bottom panel, also represented with green, and showed that the redirected stem cells significantly reduced the early stage of apoptosis in the border zone of the MI heart, and that's quantified on the right, so you can see that there. The platelet bispecific antibodies that were inhaled had much lower levels of caspase-3 and cleaved PARP. We also looked at inflammatory-related mRNA levels, and we investigated this with qPCR. And so the levels of the inflammatory mRNAs, which were MMP2, MMP9, and IL-6, were all reduced with the platelet-targeting bispecific antibodies. And then looking at the anti-inflammatory IL-10, that expression increased. So not only is it not pro-inflammatory, it's having an anti-inflammatory effect. Again, for confirmation, we did Western blotting, and the relative protein levels reflected the mRNA levels we just saw, which indicated that the inhalation of platelet-targeting bispecific antibodies induced an anti-inflammatory environment, which is beneficial for cardiac repair. And we further investigated the anti-inflammatory macrophage or microenvironment, and this involved studying macrophage polarization. So we did a similar experimental design, but instead of having treatment groups with treatment groups as before, this time we had platelet targeting bispecific antibody inhalation, non-targeting bispecific antibody inhalation, platelet targeting bispecific antibody inhalation, or antibodies by IV injection, and then PBS inhalation for our controls. And instead of only waiting 3 days after treatment, we extended the endpoint for 2 weeks. And looking at the macrophages, we identified macrophages with CD68 and quantified that by confocal microscopy, in which the percent of CD68 pixels that also overlapped with DAPI were measured. And during the course of the study, the percent of CD68 positive macrophages increased at a faster rate in the platelet targeting bispecific antibody group than the rest of the groups. However, by 14 days, all groups had similar levels of CD68 positive macrophages. And this trend was also observed when quantifying the pro-inflammatory M1 macrophages and the anti-inflammatory M2 macrophages, where animals were treated with platelet targeting bispecific antibodies. There's that gradual increase in M2 macrophages, the anti-inflammatory macrophages, that's highest at day 7, and then that lowers again by day 14. We further studied this with flow cytometry, which enabled identification of macrophages based on phenotype. So all macrophages were stained with CD11b for identification, and because we were using mouse macrophages, we also stained with F480. And so M2 macrophages were identified with the additional staining of CD206. And then we also looked at a subtype, CCR2 macrophages. And so you can see initially at 4 hours after MI surgery at the top, there's many more M1 macrophages than M2 macrophages. However, the percent of M2 macrophages increases from 4 hours to 3 days after MI surgery. And then again, by day 14, it's decreasing. And the panel to the right is a quantitative description of the flow cytometry results. And this depicts the ratios of M1 to M2 macrophages. So we have the CCR2 positive macrophages as well. And those are considered pro-inflammatory and those decreased throughout the study, as you can see on the right. CCR2, just a bit more clarification, that's a receptor to chemokine CCL2, which is released by neutrophils, and that's part of the natural immune response where they conduct cardiac repair. So we also did look at neutrophils separately, but we weren't able to identify a significant difference in neutrophil counts between the platelet targeting bispecific antibody group and any of the other MI groups. So at this point, I will be turning this back to Tanya for a quick audience poll.
Great, thanks Hallie for the fascinating discussion so far. We wanted to give Hallie a chance just to grab a drink of water, catch her breath, and during this time it would be great to learn a little bit more about the research that you are doing. So we have two different poll questions. The first one is, what kind of work are you currently focused on? And please feel free to select any of the results that apply to the work that you're doing. So that would include mouse models of cardiac disease, including myocardial infarction, hematopoietic stem cells and the possibility of their therapeutic benefit, targeted antibodies and their use, again, for therapeutic benefit. And if you're doing something else and you want to share with us, feel free to use the chat window and we'll just take note of it there. The second question is, are you doing in vivo or in vitro work? Again, feel free to choose the results that are most specific to you. So if you're only using in vivo work, or if you're doing both in vitro and in vivo, feel free to pick A and B. And then if you want to provide any more details on the work that you're doing, again, feel free to use the chat window as well. I'm going to give everyone just another couple seconds to finish answering those up for us. Excellent. So it looks like there's almost everyone on the call is doing some type of in vivo work, and there's some doing some in vitro work, focusing a lot on myocardial infarction and different mouse models, some studying hematopoietic stem cells and antibodies as potential therapies as well. So thank you everyone for taking the time to answer those questions for us. And at this point, I'll turn things back over to Hallie to finish up today's webinar.
All right, so after looking at the macrophages, we also moved on to examine the therapeutic effect of platelet targeting bispecific antibodies on cardiac repair of the myocardial infarct heart. So 4 hours after receiving MI surgery, cardiac function was examined with echocardiograms, and we used this as the baselines for the mice. The next day, the mice were divided into 4 treatment groups. One group received the platelet targeting bispecific antibody inhalation therapy. One group received non-targeting bispecific antibody inhalation therapy. One received the platelet targeting bispecific antibody IV injection therapy, and the last group just received PBS inhalation therapy. So 3 weeks later, we subjected the mice to another round of echocardiograms, and we did this to determine changes in left ventricular end-diastolic and systolic volumes, left ventricular ejection fraction, and left ventricular fractional shortening. And we found that left ventricular end-diastolic volume, which is the filling volume of the left ventricle, that increased over the 3 weeks with the platelet targeting bispecific antibody therapy, and this increased to a healthy volume, though to a lesser extent than the other treatment groups. The left ventricular and systolic volume, which is the volume left in the heart after the left ventricle has contracted, was reduced in comparison to the other groups. And we also looked at left ventricular ejection fraction, which is the percent of blood expelled from the heart, or the end systolic volume divided by the end diastolic volume, and left ventricular fractional shortening, which is the percent change in the diameter of the left ventricle. And both of these increased with platelet targeting bispecific antibody therapy. And again, inhalation administration was more effective than tail vein injection in all cases. So we used the Syntica Prospect T1 to obtain these echocardiogram values. And the setup looks like this with the touchscreen tablet, the mouse stand, and the probe. And here are representative echoes of mice from each group. Visually, you can see the differences in how much the heart contracts. Interestingly, despite the attenuation of the cardiac remodeling from IV injection of platelet targeting bispecific antibodies being better than the saline and non-targeting bispecific antibody groups, The IV injection of platelet-targeting bispecific antibodies still resulted in lower left ventricular ejection fraction and fractional shortening values compared to those who received inhalation therapy. And here, the proliferation of cardiomyocytes is depicted with Misson's trichrome staining of the hearts, with the blue demonstrating fibrosis or lack of cardiomyocyte proliferation. And so, as we know, under ischemic conditions, cardiomyocyte proliferation is reduced. And in this graph, you can see that inhalation therapy of the platelet-targeting bispecific antibodies increased viable cardiac area more than any other group, and the infarction size is lower than in any other group, indicating that the infarction was attenuated by platelet-targeting bispecific antibodies. The hearts were also analyzed for how the platelet-targeting bispecific antibody inhalation therapy would affect the microenvironment. So we did fluorescent staining of the hearts and showed that stem cells were redirected to the border zone of the MI heart, where the hearts we labeled red with alpha sarcomeric actin, and the stem cells were labeled green with CD34. And analysis showed that there was approximately 3 times as many stem cells in the heart from inhalation therapy in comparison to the heart with IV injection therapy. And then for the platelet targeting bispecific antibodies, we had 6 times as many stem cells there in comparison to the non-targeting bispecific antibodies. And below that, looking at the apoptosis with a tunnel assay, the platelet targeting bispecific antibodies led to a reduction in apoptosis. Conversely, looking at proliferation, inhalation of the platelet targeting bispecific antibodies increased proliferation to almost 3 times as much as IV injection, and again, 6 times as much as the non-targeting bispecific antibodies and saline-treated groups. And we determined this by staining for Ki67. We use this as a proliferative marker because this is expressed during the G1, S, and G2 stages of the cell cycle. We also looked at capillary density, and again, we stained capillary or the vasculature with von Willebrand factor. And this was used as an indicator of angiogenesis here in the heart. And here it's represented with red staining. So platelet targeting bispecific antibody inhalation therapy produced the most red or the most capillary density at the border zone of the infarct heart. And mirroring the other results, we had approximately 3 times the amount of vasculature with the inhaled bispecific antibodies as opposed to the IV injected bispecific antibodies, and then 5 times that of the mice treated with non-targeting bispecific antibodies or saline. And the extent of fibrosis, which occurs with the remodeling of the extracellular matrix and is natural, but in excess can lead to heart failure, was examined based on the amount of alpha smooth muscle actin. And unlike the previous measurements, which we based on fluorescent staining, we used Western blotting for this, and we studied the relative expression levels of alpha smooth muscle actin with normalized to GAP-DH. And the much paler band here demonstrates that the platelet targeting bispecific antibodies were able to greatly reduce the amount of fibrosis. So in conclusion, we found that platelet targeting bispecific antibodies can direct hematopoietic stem cells from the lung to the heart. And we showed that lung-derived hematopoietic stem cells can improve cardiac repair. It doesn't have to be bone marrow-derived stem cells. And they will also mediate inflammation in the MI heart within a short period of time. We also showed that lung hematopoietic stem cells polarize cardiac macrophages towards the anti-inflammatory phenotype and pro-regenerative macrophage phenotype. We also found that platelet targeting bispecific antibody treatment increased angiogenesis and reduced apoptosis in the border zone of the MI heart. And lastly, inhalation of the platelet targeting bispecific antibodies had greater efficacy beyond that of IV injection. So the next steps for our study involve evaluating the efficacy of using the FAB fragments or the SCFB instead of using platelet targeting bispecific antibodies, and we will also be conducting a toxicity study. So a big thanks to Doctors Chang and Liu for leading this study, everyone else for helping, and the American Heart Association for funding. And thank you to Syntica for having me. So at this point, I'll be turning it back over to Tanya.
Great. Thanks, Hallie, so much for the great presentation. Just before we start the question and answer period, we did want to take this chance to launch just one last poll. And in this one, just hoping to understand a little bit more about the different techniques that you're using in your research. So today, Hallie spoke a lot about ultrasound imaging, confocal, flow cytometry, optical imaging, and different other techniques that would be great to understand if you're also using these types of techniques in your work. And then secondly, Syntica instrumentation represents a number of different manufacturers, including that of the ultrasound system used by Hallie. And we're just wondering if it would be appropriate to reach out to talk to you specifically about that ultrasound system or any of the other instruments that she spoke about, although not the specific ones that Hallie used. We do have that type of equipment, and we'd be happy to reach out to you and discuss those options offered again by Syntica. So we'll give everyone just a couple more minutes or a couple more seconds, sorry, to answer those questions. And while you're thinking about those, also, if you have any questions about the work that Hallie presented, please feel free to use that Q&A dialog box, and we'll work through some of those questions with Hallie in the time that we have remaining. Great. Thank you, everyone, for taking the time to answer those questions. I'll ask Hallie to advance just to the next slide, and we'll get started with the Q&A session. Perfect. So Hallie, we have a few questions that have come through. The first one, let's start with, my apologies. Why do you think the inhalation therapy worked better than the IV injection for the delivery of the bispecific antibodies?
We expect it works better because inhalation gives you direct delivery to the lungs. So the bispecific antibodies can bind most to or they have the greatest potential for binding to the stem cells and the platelets. Whereas if you do IV injection, the bispecific antibodies are pushed into the bloodstream and can be lost to off-target sites.
That makes sense. And forgive my naivety here, just expanding on that question a little bit. Did the antibodies that you developed, were they specifically targeted to hematopoietic stem cells from the lungs, or could they have bound to stem cells, for example, in the bone marrow?
If the stem cells were released by bone marrow and released into the bloodstream, they could have also bound there. It's just less likely because you also have all those platelets in the lungs that will be directing it to the heart. So even though it would bind, it wouldn't necessarily provide targeting to the infarct area.
Got it. Perfect. And something that perhaps I think you mentioned you may be looking into later, but did you notice any other side effects of the treatment?
We focused with side effects basically just with histology. So when we looked at the major organs, just like the lungs, the hearts, livers, kidneys, and spleens of the mice, we didn't see any abnormalities in the histology. So we don't expect there was any, but we would need to look into toxicity in terms of also like dose response.
Perfect. In some of your work, you showed that you were looking at the fluorescence signal coming from the ex vivo tissue. And I'm just wondering did you try and do the fluorescence imaging in vivo and in that way giving you the ability to track where those stem cells were going longitudinally in vivo?
We did not. We did everything ex vivo for the IVUS imaging.
Okay. In the cardiac data, the cardiac function data that you presented using the Prospect system, you talked about the filling volume and that being the end diastolic volume. While describing the results, you mentioned that after treatment, the volume showed some of an increase, but not to the same extent as the untreated group. Can you just describe that a little bit more? And again, why this would seem to be a good outcome from the treatment?
Yeah. So we did want to see an increase in filling volume, but having a much larger filling volume isn't necessarily good. And as we saw with the Masson's trichrome staining, it could be indicative of fibrosis rather than the proliferation of cardiomyocytes.
Perfect. When considering the surgery to cause the myocardial infarction, you did an LAD ligation. Was it permanently occluded?
I believe it was temporarily occluded, but I can check on that. I didn't do the surgery myself.
Okay. The question from that just becomes, if it was a permanent occlusion, how would the hematopoietic stem cells then home to the downstream area of the infarct, or would you see them going more into the gray zone area around the infarct and then helping to heal the tissue from there?
Yeah, I believe what we do for MI surgeries is 1 hour of ligation. And so after that hour, then it's the ligation is cut. But so yes, that would, if it were ligated still, I can see why it would be questionable of how the stem cells were getting there. But I do believe it's only temporary, and that's why the stem cells were still able to travel through.
Perfect. Another question, similar beneficial results have been found using sorry, my words are not coming to me today. Exogenously delivered hematopoietic stem cells that are CD34 positive. Did you compare the homing to the heart with such exogenous CD31 positive cells to see if using the bispecific antibody approach would be any better?
I'm sorry, can you say that one more time?
Yeah, sure, I'll try. One of the researchers has mentioned that similar beneficial results have been found using exogenously delivered hematopoietic stem cells that are CD34 positive. Did you compare the homing to the heart with such exogenous CD34 positive cells to see if the bispecific antibody treatment was any better or could improve those results?
No, we used all the cells were native to that particular mouse.
Okay, great. That's all the questions we've had come in thus far. I just wanted to invite anyone remaining on the webinar, if they have questions, to feel free to answer them or put them in the Q&A dialog box, and I'll help deliver those to Hallie as best I can. So we'll just give everyone a couple more minutes. And I'd like to, at this point, as we wait for those questions to come in, thank everyone for taking the time to join us today. And I hope that you all found Hallie's presentation relevant to the work that you're doing and informative in terms of taking a look at those hematopoietic stem cells and how they can help with myocardial repair. I'd like to thank Hallie for taking the time to present with us today and to address any of the questions that you did that we posed to her. And I just wanted to invite anyone, if in the days and weeks to come that you have further questions about the work that Hallie discussed, I'm happy to connect you with her. Or if you have questions about any of the equipment, including the Prospect T1 from Syntica, I'd encourage you to reach out and we'll be happy to discuss your specific research and how those pieces of equipment may be able to help move your research forward. And one more question came in. Hallie, do you have any information on the PK of the bispecific antibody with the two routes? I would presume inhalation versus injection.
I personally don't, but I can check and see if we did that study and get back.
Perfect. Well, Hallie will look into it, and if we have, we'll include the response in the document that we send out to everyone in the next couple of days. Perfect. At this point, I'd like to give you all back 20 minutes to your day because I know everyone's very busy. And I'd like to thank everyone for taking the time to join us today. And we do look forward to seeing you at any future Syntica webinars that are relevant to the work that you're doing. Thanks again, everyone. And thanks, Hallie, for the great presentation today.
Yeah, thank you. And thanks to everyone else.